Hello and welcome to Insider Ophthalmology Simplified. In today's class, we are going to discuss regarding steroid-induced glaucoma, which is a very high-yield topic commonly asked in clinicals as well as viva. Also theoretically, it is very important and we need to know it for clinical purpose also. In this class, we will discuss what are the types of steroid responders, who are non-responders, who are high responders, the pathophysiology, risk factors, the steroid formulations and doses which cause glaucoma and how much time it takes to form glaucoma, and its management. Okay, so basically it's glaucoma which is caused due to the use of steroids. Okay, and coming to the types of steroid responders, there are non-responders or low responders, intermediate responders and high responders. So this is based on Armali-Baker's classification. So in non-responders, the IOP rise is less than 20 mm of Hg. In intermediate it is 20 to 31, and in high responders it is more than 30 mm of Hg. So 60% of the population are non-responders, 36% are intermediate responders, and high or steroid responders are 4% of the population. So this is the type of steroid responders in the community or the population. And the risk factors associated with this are the open angle glaucoma. So the patients who are already having open angle glaucoma, the ones with diabetes, myopes, patients with angle recessions and collagen vascular diseases like rheumatoid arthritis. So these are all the risk factors. The patient with open angle glaucoma have very high tendency for steroid response and intermediate steroid response and high steroid response. Okay, so the first generation relatives of the open angle glaucoma patients and all, so these are the risk factors. So coming to the steroid formulations, so we have topical steroids, periocular as well as systemic steroids, which are most commonly associated with the development of glaucoma. Whereas this intranasal and the cream preparations, these cause glaucoma on a very long run. Now this was just a introduction type. Coming to the actual pathophysiology of how this steroid induced glaucoma occurs. Okay, so what do these steroids do inside the body? So corticosteroids, they increase the deposition of extracellular matrix at the trabecular meshwork. They inhibit phagocytosis by the endothelium of trabecular meshwork, thereby increasing the waste material. Okay, it reduces the expression of extracellular matrix proteases, which are fibrinolytics and matrix metalloproteases. So these break down the ECM. These are reduced and deposition of ECM is increased. It also reduces the expression of TIGR gene, which in turn reduces the expression of matrix metalloproteases. It also reduces PGF2 alpha, which is an outflow enhancer or facilitator. So in this way, there is increased deposition of ECMs and the debris in the extracellular matrix, which in turn causes open angle glaucoma. Now coming to the drugs, the steroid formulations which cause glaucoma, the risk is directly proportional to its potency, the risk of development of glaucoma. So the high potent drugs include betamethasone, dexamethasone, prednisolone, whereas low potency drugs include loteprednol, fluorometholone and remixolone. Intravitreal injections have very high chances of development of glaucoma, so it usually occurs earlier in cases of intravitreal triamcinolone injections. And we also have skin preparations and intranasal, that is usually prescribed by the ENT for asthmatics and all. So these also contains glaucoma. So the high potency skin preparations include clobetasol, betamethasone, and the low potency or intermediate potency is the hydrocortisone. So we need to monitor, we need to take a proper history of these things also, because we just miss this, and patient also does not consider this as a specific medication, okay, unless until it is taken by oral route, they don't consider it as a medication. Understood? So we have intranasal preparations like dexamethasone and budesonide, which are high potency, whereas fluticasone is a lower potency drug. So yes, intravitreal injections may lead to glaucoma or the IOP rise within 1 to 2 months, whereas high potency drugs may cause within 3 to 6 months of use, and low potency drugs will take more than 1 year for the development of glaucoma. So this is very important to remember this table. Coming to the management, either we have to stop and then switch to either low potency drugs, non-steroidal anti-inflammatory drugs, steroid sparing formulations such as immunosuppressants, and we also can perform selective laser trabeculoplasty, argon laser trabeculoplasty, and even if it fails, then we have to go for surgery. It is commonly indicated if the age is less than 20 years because the risk of development of optic atrophy glaucomatous is more. So this was regarding steroid induced glaucoma. I hope you liked this video. Please hit the like button, share it with your fellows, and also subscribe to my channel for such more informational videos. Thank you for watching. Bye bye.